Hello and welcome to JCO Article Insights episode for the December issue of the Journal of Clinical Oncology. I'm your host, Gisele Carvalho, medical oncologist in Brazil, focusing on breast cancer and melanoma skin cancers, and one of the ASCO editorial fellows at JCO this year. Today, I will be discussing two articles. The first one is Navigating Treatment Pathways in Metastatic Hormone Receptor-positive HER2-negative breast cancer, optimizing second-line endocrine and targeted therapies. And the second one is the U.S. FDA approval summary on Capivasertib with fulvestrant for HR-positive HER2-negative locally advanced or metastatic breast cancer with PIK3CA AKT1 PTEN alteration. As we know, 65% to 70% of all breast cancers are HR-positive HER2-negative, and this is also the most common subtype of metastatic breast cancer. The current standard of care for frontline therapy of patients with luminal metastatic disease is a CDK4/6 inhibitor in combination with endocrine therapy. However, as new endocrine and targeted therapies gain approval, choosing the best systemic therapy upon disease progression after frontline therapy is a topic of ongoing debate. Nearly 40 to 50% of HR-positive breast cancers have actionable genomic alterations, and molecular testing should be a routine recommendation for patients with metastatic HR-positive HER2-negative disease. This can be performed repeating tissue biopsy at the time of progression or from archival tissue. Treatment options after progression on CDK4/6 inhibitors include alpelisib in combination with fulvestrant in patients with PIK3CA mutant tumors, as seen in the SOLAR-1 trial, or Capivasertib with fulvestrant in patients with a tumor mutation in PI3K AKT PTEN pathway, as seen in the CAPItello-291 study, which will be discussed further. In approximately 30% of patients, progression on frontline endocrine plus CDK4/6 inhibitor treatment is caused by endocrine resistance, frequently involving activating mutations in ESR1. For those tumors, elacestrant, an oral SERD, is an option as demonstrated in the EMERALD trial. For patients with a BRCA mutation, PARP inhibitors represent another option. If no mutations are detected, everolimus, an mTOR inhibitor, can be used based on the BOLERO-2 results. The Phase 2 MAINTAIN and PACE trials, along with the Phase 3 post-MONARCH trial, support changing the endocrine therapy backbone with or without switching the CDK4/6 inhibitor. In less resourced areas, fulvestrant monotherapy is still an option to delay cytotoxic chemotherapy, though its efficacy is limited when used as a single agent. Finally, after progression on at least one line of chemotherapy, antibody-drug conjugates, including sacituzumab govitecan or trastuzumab deruxtecan, may be an option. Now, focusing on the PI3K AKT PTEN signaling pathway, activating mutations in PIK3CA and AKT1 and inactivating alterations in PTEN occur in approximately half of luminal breast cancers. In June 2023, the CAPItello-291 trial was published, and treatment with fulvestrant plus Capivasertib, a pan-AKT inhibitor, demonstrated a 3.6-month PFS benefit compared to fulvestrant alone, regardless of the presence of AKT pathway alterations. However, for those with tumors without AKT pathway alteration, an exploratory analysis showed that although there was a numerical improvement in PFS, it did not meet statistical significance, indicating that the biomarker-positive population primarily drove the positive results noted in the overall population. Therefore, Capivasertib plus fulvestrant was approved by the U.S. FDA in November 2023 exclusively for patients with PI3K AKT1 PTEN tumor alterations after progression on an aromatase inhibitor with or without a CDK4/6 inhibitor. The approved schedule of Capivasertib is slightly different from that of other agents used in breast cancer. It is 400 milligrams taken orally twice a day for 4 days per week, every week in a 28-day cycle, in combination with fulvestrant. Diarrhea, rash, and hyperglycemia were the most commonly reported grade 3 or 4 adverse events in the interventional group. I would like to highlight that even though the Capitello trial excluded patients with glycosylated hemoglobin levels higher than 8% or those diagnosed with diabetes who required insulin, hyperglycemia occurred in 19% of biomarker-positive patients treated with capivasertib, with nearly 2% of this population experiencing grade 3 or 4 hyperglycemia, and some patients experiencing life-threatening outcomes such as diabetic ketoacidosis. By way of comparison, hyperglycemia of any grade was 3 times higher with alpelisib therapy in the SOLAR-1 trial, occurring in 64% of the patients, and grade 3 or higher hyperglycemia was seen in 37% of the patients. Diarrhea was the most common treatment-related adverse event experienced by 77% of the biomarker-positive population. Prompt use of the antidiarrheal drugs when needed, such as loperamide, must be encouraged, as untreated diarrhea can lead to dehydration and renal injury. Cutaneous rash occurred in 56% of the biomarker-positive population in the interventional group, and 15% experienced grade 3 or 4 rash. Nearly half of the patients with cutaneous adverse reactions required treatment, and this was the leading reason for dose reduction of capivasertib. In the biomarker-positive population, the improvement in median PFS were 4.3 months by investigator assessment. Overall survival data from the Capitello 291 trial is still immature, but quality of life data was recently published in September this year and was assessed by the 30-item QLQ-C30 questionnaire and the QLQ-BR23, the BRAS module. According to Oliveira et al., global health status and quality of life were maintained for a longer period with capivasertib fulvestrant than with placebo fulvestrant, except for symptoms of diarrhea, which were significantly worse in the capivasertib group. The median time of deterioration of global health status and quality of life was twice as long in the capivasertib group, being almost 25 months versus 12 months in the placebo fulvestrant group. These data reinforce the use of capivasertib in combination with fulvestrant for the treatment of HR-positive HER2-negative advanced breast cancer patients with PIK3CA, AKT1, PTEN tumor alterations who have progressed after an aromatase inhibitor-based therapy with or without a CDK4/6 inhibitor. Thank you for listening to JCO Article Insights. This is Gisele Carvalho. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcasts. See you next time.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.